In section 2, we will look at the importance of the oral phase of digestion, which is comprised of secretion of saliva, mastication, and swallowing. In the second module of GI physiology, we'll be talking about the oral phase of digestion. First of all, it's important to have a good understanding of the physiology of the oral cavity. There are 3 salivary glands, namely the parotid gland, the submaxillary or submandibular gland, and the sublingual gland. These glands have different histological types. The parotid gland is mainly a serous gland, sublingual gland is mainly mucus, and the submaxillary or submandibular gland is a mixed gland with both serous and mucus production. Salivary glands secrete between 1 and 1.5 liters of saliva per day. The acinar cells in these glands secrete water, ions, mucus, and enzymes, which pass through the salivary duct, and the cells of the salivary duct modify saliva. Myepithelial cells which surround the acini and the ducts contract to eject saliva. 2 different types of digestive enzymes are secreted. These are lingual lipase and salivary amylase. The function of these enzymes is to act as solvents, lubricants, and they keep the mouth and teeth clean as they have some antibacterial activity. Problems with secretion or production of salivary enzymes is manifest in xerostomia, where there's deficient salivation and the higher incidence of dental caries. The parotid gland produces more serous secretions than mucus secretions, and is the only salivary gland innervated by cranial nerve 9. Tumors of the parotid gland are usually adenomas. The sublingual and submandibular gland are innervated by cranial nerve 7 or the facial nerve, and they have a predominant mucus secretion rather than serous secretion, and tumors of these glands are mucoepidermoid in nature. The primary secretion in the acini is isotonic. In that respect, the ionic concentrations are close to those in plasma, and saliva is actually modified in the excretory ducts. In these ducts, sodium and chloride is resorbed by the ductal cells, and potassium and bicarb is secreted by ductal cells. The ducts are relatively impermeable to water. This is important because the salivary flow rate therefore determines ion concentration. At high secretory rates, ionic composition more closely resembles that of plasma, as this is what's present in the acini at the time of secretion. At low rates, saliva becomes more hypotonic. Saliva is never hypotonic. Aldosterone also modifies ionic content by increasing potassium and decreasing sodium concentrations, as it does in the kidney. It does not, however, regulate flow. Bicarbonate secretion is stimulated by parasympathetic input and increases at higher flow rates. So control of salivary secretion occurs in a number of different ways. Taste, chewing, smell, and nausea all stimulate the salivary nuclei in the medulla. Therefore, the Pavlovian dog response with production of salivation to particular stimuli or smell is explained by this fact. Increased sleep, fatigue, dehydration, and fear negatively inhibit the salivatory nucleus in the medulla. This also explains why during times of extreme nervousness we always seem to have a dry mouth. Stimulation of the salivatory nuclei in the medulla results in parasympathetic activation through cranial nerve 9 and cranial nerve 7. This results in the release of acetylcholine and second messenger activation via IP3, resulting in the release of calcium and eventual secretion of saliva. Sympathetic nervous system activation also occurs via T1, T2, and T3 in the superior cervical ganglion. Norepinephrine is released, and CAMP, second messenger systems, are activated. Therefore, both the parasympathetic and sympathetic systems come together, resulting in the release of saliva. Sjögren's syndrome is a chronic autoimmune disorder which is characterized by xerostomia, which is a dry mouth, xerophthalmia, or dry eyes. It's manifest by lymphocytic infiltration of the exocrine glands. This triad is also known as the Sicker complex. Sjogren's syndrome can be part of other disorders, such as rheumatoid arthritis, or can exist on its own. Inflammation or infections of the salivary glands also occur. Parotitis represents inflammation or infection of the parotid gland. The most common organism associated with this is Staph aureus, and is often introduced by intubation, regardless of the type of surgery. Viral parotitis also occurs and is usually associated with mumps. Siladnitis or siladnosis is infection of the salivary gland and usually involves the submandibular gland. This may often be due to a retained stone in the salivary gland, which prevents emptying of salivary contents. Peritonsillar abscesses are suppurative infections of tissues adjacent to the palatine tonsils. These are the most common abscesses of the head and neck region and need to be recognized clinically. Because they involve the airway, when they enlarge significantly, patients can present with stridor and in respiratory distress. In those cases, these abscesses need to be drained, often surgically. Uvulitis is inflammation of the uvula and most often caused by Haemophilus influenza type B. Group A strep are also associated with these. Patients with uvulitis will often present with choking because the inflamed enlarged uvula is touching the back of the tongue, and so the gag reflex is initiated. Uvulitis often resembles a Swedish fish because the uvula, which is enlarged and lies draped over the tongue, looks like a small Swedish fish. Tumors of the salivary glands also occur. The most common is a pleomorphic adenoma, which is known to have a high recurrence, and the second most common is a Warden's tumor. Mucoepithelioid adenocarcinomas are also associated with the salivary glands. Chewing is an important and yet often overlooked part of the digestive process. Chewing occurs to make it easier to swallow food. It mixes food with saliva, therefore lubricating it, and reduces the size of the food particles. This facilitates swallowing. Salivary amylase, previously known as ptyalin, begins digestion of ingested starches, and lingual lipase acts on the triglycerides. Mastication stimulates the taste buds, increases the pleasure of eating, and also initiates gastric secretion, which is another phase of digestion. This is important because I really want you to think about digestion as a process that's occurring in different parts of the body. We've broken it up into different phases for the purposes of this module, but really the act of smelling, swallowing, and then chewing food stimulates the gastric phase of digestion as well before food has arrived in the stomach. Much of the chewing process is caused by the chewing reflex, and the number of chews that are optimal depends on the type of food, and usually ranges from 20 to 25. Salivary amylase or ptyalin is secreted mainly by the parotid glands. It acts by hydrolyzing starch into alpha-limit dextrins, maltotriose, maltose, and isomaltose. It is deactivated by a gastric pH below 4.0 and therefore is not active in the stomach. Lingual lipase is secreted by the Ebner's glands on the dorsal surface of the tongue. This remains active in the stomach and can digest as much as 30% of dietary triglyceride. Kallikrein is an enzyme that cleaves high molecular weight kininogen into bradykinin. Bradykinin is a potent vasodilator, causing vasodilatation during times of increased salivary production. This increases the blood flow to the salivary glands, therefore facilitating this process. The upper GI tract consists of the pharynx, the esophagus, and the stomach. There are two main sphincters that are present, the upper esophageal sphincter and the lower esophageal sphincter. The pharynx consists predominantly of striated muscle, and the esophagus and the stomach contain smooth muscle. This becomes important when considering the different phases of swallowing, both voluntary and subsequently involuntary. Swallowing is initiated voluntarily in the swallowing center in the medulla, and the process is completed as a reflex. In the oral phase, the tongue pushes a food bolus back, sensory receptors are stimulated, and involuntary swallowing is initiated. In the pharyngeal phase, the soft palate rises to block off the nasopharynx. This prevents food from coming out of your nose. Then the palatopharyngeal folds on either side of the pharynx are pushed medially, and the epiglottis moves to cover the trachea. Otherwise, food would go down into the lungs and we would all choke. This is really important in patients who've had strokes. The swallowing reflex is impaired. Patients have impaired swallowing, and therefore food goes down into the lungs, and this is why a lot of the time when patients have had strokes, they're not allowed to take food by mouth and will be fed via an NG tube or through a PEG tube. After the epiglottis covers the trachea, the upper esophageal sphincter relaxes, allowing entry into the esophagus. Food is then propelled by peristalsis, and during this time, breathing is inhibited. In the esophageal phase, the upper esophageal sphincter closes behind the food bolus, preventing regurgitation back into the mouth. And there's a primary peristaltic wave which takes food down from in the esophagus into the stomach. There are secondary waves which are initiated in the esophagus, which, if necessary, propel food down into the stomach. In this section, we discussed the oral phase of digestion. The important take-home points are to understand the important role that saliva plays in the digestive process, as well as to understand the physiology of the swallowing reflex for the purposes of the exam.